In this presentation, we are going to discuss the disorders of calcium and phosphorus. The learning objectives for this talk, we will review the hormonal regulation of calcium and phosphorus homeostasis, the etiology, clinical manifestations, and treatment of hypercalcemia and hypocalcemia. We will review also the etiology, clinical manifestations, and treatment of hyperphosphatemia and hypophosphatemia. Calcium and phosphorus regulation involves three tissues, namely the bone, kidney, and intestine. It also involves three hormones, PTH, calcitonin, and activated vitamin D. About 98% of calcium is stored in cells and bones. The remainder circulates in blood as ionized calcium in 50%, bound to proteins such as albumin in 40%, and bound to citrate or phosphorus buffers in 10%. Now, about 85% of phosphorus is stored in the bone, 14% is stored intracellularly, and only 1% is present extracellularly. Inorganic phosphorus plays a critical role in skeletal development, cell membrane integrity, and function as phospholipids. It also critical in intracellular signaling, platelet aggregation, and energy transfers in the cells. Here is the summary of the interactions between the three different organs and hormones involved in the homeostasis of calcium and phosphorus. The calcium concentration in plasma is tightly controlled as free calcium and bounded to proteins. A regular daily diet would contain around 400 milligrams of elemental calcium, of which 30 to 35% is absorbed in the intestines. Vitamin D increases the absorption of both calcium and phosphorus in the intestine. Vitamin D also favors the reabsorption of phosphorus in the proximal tubule. As a feedback mechanism, the vitamin D inhibits the production of PTH hormone. Now, PTH is secreted by the chief cells in the parathyroid gland. It stimulates the osteoclast to increase the concentration of calcium in blood. It also favors the tubular reabsorption of calcium and stimulates the production of 1,25-hydroxy-vitamin D in the kidneys. On the other hand, calcitonin, which is a hormone secreted by the parafollicular cells of the thyroid gland, acts in the bone, inhibiting bone resorption. PTH is mainly secreted in response to hypocalcemia. In normal circumstances, after heat release, the serum calcium levels will increase, while normal phosphorus levels are maintained. As we mentioned before, PTH acts directly in the bone, increasing the activity of osteoclast. It also increases the calcium levels, stimulating its absorption in the renal tubules. PTH indirectly acts, increasing the calcium reabsorption through its stimulation on the synthesis of 1,25-hydroxy-vitamin D in the kidneys. Now, let's review the role of vitamin D. Vitamin D2 or ergocalciferol is derived from plants, while vitamin D3 or cholecalciferol is derived from animal sources such as fish oil. Both vitamin D2 and vitamin D3 are hydroxylated in the liver to 25-hydroxy-vitamin D and then converted in the kidneys to 1,25-hydroxy-vitamin D3 by the 1-hydroxylase. Vitamin D increases the intestinal absorption of both calcium and phosphorus in the intestine and inhibits the synthesis of PTH. Let's review the topic about hypercalcemia. Hypercalcemia may cause different symptoms at the neurologic, gastrointestinal, renal, and cardiovascular systems. In the neurologic system, hypercalcemia results in decrease of mental activity, and patients might manifest lethargy and confusion. At the gastrointestinal system, hypercalcemia results in decreased bowel activity, and patients might manifest constipation, anorexia, but commonly also produce nausea and vomiting. Pancreatitis occurs because of precipitation of calcium in the pancreas. However, severe pancreatitis is associated with hypocalcemia because of binding of the calcium to fat. Ulcer diseases is caused by hypercalcemia for unclear reasons. In the renal system, hypercalcemia results in polyuria and polydipsia because of the induction of nephrogenic diabetes insipidus. Calcium also precipitates in the kidney, resulting in both kidney stones and nephrolithiasis. In the cardiovascular system, hypercalcemia might play a role in hypertension. 30 to 50% of patients with hypercalcemia have hypertension. The EKG will show a short QT. Etiology. The most common causes of hypercalcemia is primary hyperparathyroidism. The majority of patients with hyperparathyroidism do not have symptoms, and the diagnosis comes to light because of routine office-based testing. The hypercalcemia of malignancy occurs due to a PTH-like protein and metastatic disease to the bone. Granulomatosis diseases such as sarcoidosis, tuberculosis, berylliosis, histoplasmosis, and coccidioidomycosis are all associated with hypercalcemia. This may be of increase of vitamin D production. Rare causes of hypercalcemia include the use of thiazide diuretics, Paget's disease of the bone, vitamin D intoxication, and prolonged immobilization. Hyperthyroidism is also associated with hypercalcemia because of a partial effect of the thyroid hormone on osteoclast activity. Treatment of hypercalcemia. Severe, life-threatening hypercalcemia is treated first with aggressive fluid replacement using normal saline. This is usually followed by the use of loop diuretic such as furosemide, which promote calcium loss from the body. Biphosphonates such as alendronate, solendronate, and pamidronate all inhibit osteoclast and stimulate osteoblast. However, the maximum effect of biphosphonates takes 2 to 3 days. Calcitonin can be used for a more rapid decrease in calcium level. Calcitonin works inhibiting the osteoclast activity. Primary hyperparathyroidism. Primary hyperparathyroidism represents 90% of mild hypercalcemia. It is most commonly due to one gland adenoma in 80% of the cases, but hyperplasia of all 4 glands can lead to primary hyperparathyroidism in 20% of the cases. Parathyroid cancer is a rare cause of this disease and is present only in less than 1%. Primary hyperparathyroidism can occur as part of MEN, or multiple endocrine neoplasia syndrome. There are 2 kinds of multiple endocrine neoplasia syndrome. In MEN type 1, the patients suffer from hyperparathyroidism, pituitary tumors, and pancreatic tumors. This is called the 3 Ps. In MEN type 2, the patients suffer from hyperparathyroidism, pheochromocytoma, and medullary carcinoma of the thyroid. On half of patients with hyperparathyroidism, no symptoms are found, but they might present with symptoms related to hypercalcemia. Osteoitis fibrosis cystica can be present and occurs because of increased rate of osteoclastic bone resorption and results in bone pain, fractures, swelling, deformity, and areas of demineralization, as well as production of bone cysts and brown tumors. Diagnosis and treatment of hyperparathyroidism. The diagnosis can be made by laboratory findings of serum calcium above 10.5 mg per deciliter with elevated PTH level. Serum phosphorus is usually low, less than 2.5 mg per deciliter. The differential diagnosis includes all other causes of hypercalcemia. Imaging studies are not used for the diagnosis of hyperparathyroidism. Surgical removal of the parathyroid glands is usually effective and should be performed if there are symptoms of hypercalcemia, bone diseases, or renal diseases, or if the patient is pregnant. One of the common complications of surgery is the development of hungry bone syndrome. Medical treatment is used in a symptomatic or mild increase of calcium level. For example, if the calcium is less than 11.5 milligrams per deciliter. Medical treatment is also used if there are contraindications for surgery. The medical management includes biphosphonates, reduction of calcium intake to less than 400 milligrams per deciliter, and oral hydration with 2 to 3 liters of fluid per day. Cinecalcid has also a place in the treatment of hyperparathyroidism. Hypocalcemia. Hypocalcemia results in increased neural hyperexcitability such as seizures, tetany, circumaural numbness, and tingling of the extremities. Physical findings are the known Chvostek sign, which is a contraction of the facial muscles after percussion of the facial nerve, and the Trousseau sign, which is the identical spasm of outstretched hand after inflation of a blood pressure cuff higher than the systolic blood pressure for more than 3 minutes. Of note, arrhythmia may also develop as a result of a prolonged QT. Finally, cataracts may develop for unclear reasons. Etiology and treatment of hypocalcemia. Hypocalcemia is most commonly caused by hypoparathyroidism, acute pancreatitis, and renal failure. In renal failure, hypocalcemia develops as a decrease of the 1,25-hydroxy-vitamin D production. Hyperphosphatemia might also cause hypocalcemia, vitamin D deficiency, and hypomagnesemia, which prevents the release of PTH by the parathyroid glands. Some drugs, like loop diuretics, phenytoin, alendronate, and foscarnet, will also lower calcium levels in blood. Hyperphosphatemia will cause the precipitation of calcium in tissues. Massive blood transfusions can cause hypocalcemia because of binding of the calcium to the citrate that contains the transfused units of blood. Finally, pseudohypocalcemia occurs with low albumin levels. The treatment of hypocalcemia depends on the correction of the underlying etiology, but in general, calcium should be replaced intravenously or orally, and vitamin D is often used if his replacement is necessary. Hyperphosphatemia. In general, the acute development of hyperphosphatemia does not cause symptoms unless it is associated with hypocalcemia. Persistent hyperphosphatemia occurs almost exclusively in renal failure. Acute hyperphosphatemia can result from increased intestinal absorption, like vitamin D intoxication, or after the use of high phosphorus-containing enemas. A common etiology is the rapid release of cellular content, like happens in tumor lysis syndrome after chemotherapy or in fast cells turnover. It also occurs in rhabdomyolysis, acute hemolysis, hyperthermia, or decreased renal excretion. Chronic kidney disease causes hyperphosphatemia mainly due to the inability of the kidney to eliminate phosphorus. Unfortunately, chronic hyperphosphatemia in advanced chronic kidney disease is associated with adverse sequelae, including cardiovascular disease, soft tissue calcification, and multiple bone metabolism disturbances. The treatment of hyperphosphatemia includes the use of phosphate binding agents to prevent his absorption in the gut. Hypophosphatemia. Hypophosphatemia is a common finding in hospitalized patients. It is present in 3% of all patients admitted to the hospitals. It is more frequent in patients with history of alcoholism and can be present in up to 70% of patients in the intensive care units. Hypophosphatemia is usually asymptomatic, but in moderate or severe cases, it can be manifested as muscle weakness, cardiomyopathy, and heart failure, may cause hemolysis, platelet dysfunction, and neurologic disorders. Hypophosphatemia is caused by decreased intestinal absorption secondary to the use of phosphorus binders, alcohol intake, or severe vitamin D deficiency. Hypophosphatemia can also be secondary to urinary losses like renal tubular defects, glucosuria, and hyperparathyroidism. Hypophosphatemia can be caused by cellular shift, like happens in diabetic ketoacidosis crisis, respiratory alkalosis, and angry bone syndrome. Hypophosphatemia is usually treated with intravenous or oral replacement. In general, increasing his oral intake is the preferred treatment. As a summary, calcium and phosphorus homeostasis is regulated by vitamin D, PTH, and calcitonin. Most common cause of hypercalcemia is hyperparathyroidism. Cardinal symptoms of hypocalcemia is tetany. Hyperphosphatemia is clinically most relevant when caused by tumor lysis syndrome or advanced chronic kidney disease. Hypophosphatemia is usually related to nutritional deficiencies and is extremely common in hospitalized patients. References: Greenberg, Chung, Kaufman, Falk, and Janet on Primer of Kidney Disease 5th edition. Thank you.